So good evening. Tonight we're going to do a endocrine portion, and this lecture is really a case study of a close family member of mine that I had about a month ago. And this is something that most EMTs and medics do not talk about, don't learn about. So I thought it would be appropriate and would be a good topic to discuss and maybe bring up questions if you have any. So the topic is called EDKA. This is a type of DKA that I'm sure you're all familiar with from EMT school, but this is euglycemic DKA. What does U mean? U means normal. Okay, so it's used in medicine, euthanasia, euphoria. There are many words where it is used in medicine. This is euglycemic. That means the sugar level is normal. It's at a normal range. Now, you were taught, I'm sure, in EMT school, that for DKA, you're looking at numbers above 500. If you read the literature, especially medic EMS textbooks and literature for EMS, it's going to say that DKA will present from 250 to 500. Why do they give a top number? Because the machines typically that we use don't go above that. So that's what you'll see in the textbooks and the literature. And this is a very interesting type of DKA and not a type that people are typically familiar with. So let's get into it. So we're going to call it EDKA, and it's very similar to DKA, but there are a couple of big differences. So we're not going to see polyuria and polydipsia. Okay, those are two huge signs, symptoms that you're going to see with a patient in DKA. And let's back that up even more, not only in DKA, but you're going to see this in a patient with hyperglycemia. So polyuria, much urination, polydipsia, much thirst or drinking. So this is typical for DKA, and to expand on that, for hyperglycemia. There may or may not be mental status changes in EDKA. So what are you going to see and how are you going to know the difference? So nausea, vomiting, shortness of breath are all possible. General malaise, that means feeling sick. Okay, my patient had that. Lethargy, loss of appetite, and fatigue. My patient had all of those. This is abnormal fatigue. This is going for a nap for a few hours, waking up and being tired and going back for a nap. Abnormal fatigue. I'm not talking about the fatigue of working 12 hours, getting 3 to 4 hours sleep and then again up and, at it. Abdominal pain. So they may or may not have polyuria polydipsia because the serum glucose will be normal level. So it's very difficult to diagnose this in the field, but I think that if people are aware of it and able to understand it, you may just spot it. That doesn't have to be infection or, any stresses, pregnancies, or anything like that. It can just come on, and I'll show you. My patient is a 75-year-old male. type 2 diabetic. And this is, with a blood sugar, just to add, with a blood sugar of 140. Okay, so not what you would consider horribly, majorly hyperglycemic, but he did have many of these signs and symptoms. So they may have Kussmaul respirations. I'll just quickly remind you what that is. As the ketones are being produced in the body is becoming acidic. The body has a homeostasis where it does not want to raise the acidity level or lower the pH, same thing. And the body will first try to use the respiratory system by blowing off more CO2. CO2 is an acid in the body, as opposed to bicarb, which neutralizes that and tries to make it in equilibrium that should be right. So you may see Kussmaul's respirations. They may have fruity odor or even the acetone odor. And look at these. Tachycardia. Yeah, my patient was tachycardic. Hypotensive. No. Ultimentation or EMS. No. Increased skin, turgor, delayed cab refill. These are signs of dehydration or metabolic shock, and you're familiar with that. In severe cases, dehydration, etc., lead to hypovolemic shock and coma and death. So, Baruch Hashem, my patient didn't have that. We caught it, and we got him to where we needed to go. Most patients with EDKA will recover well. Prompt recognition and treatment is what's needed. They need to get to an ICU. I would recommend NYU. That's where I took this patient, and they were there for about a week. So it's, but the prognosis was good, and they did very well. This is your normal DKA, in case you weren't sure. It's three things are going on. There's hyperglycemia, lots of blood, lots of sugar, glucose in the blood. Remember, it cannot get into the cells. So it's building up in the blood, cannot get to the cells. Why? Usually because of lack of insulin. The cells decide, we're fed up with this. We see all the sugar, but we're not getting any. And so they break down fats that are attached to the cells. They break down fats, they produce sugar, and they produce a byproduct called ketones. Ketones are what give that nasty acetone breath that you'll smell on hyperglycemic patients. Those ketones are acidic, and so the pH is going to drop. Patients are going to be acidic, and then all sorts of problems, all the way to sepsis can occur. You'll see the Kussmaul respirations to try to reduce the acidity. So what is going on? What is this EDKA, and why did it happen? Well, this is the culprit. And I'm going to teach you about a class of drugs called SGLT2 inhibitors. And this is a very common one. This is the one that my patient had been put on by his physician, Jardiance. In the last couple of months, I've met numerous patients that have had the same problem with this drug, Jardiance. If you look up this drug in a proper drug reference database, I don't mean Googling it, but a real reference, it'll tell you one of the side effects is DKA. So they're not even hiding it. So this was the drug that this patient was on. Obviously, diabetics are told, do not eat carbohydrates. And I think this drug, with the lack of carbohydrate intake, is what caused the problem. Now, these SGLT2 inhibitors, this is not the only one, but this is the one that I sort of became familiar with, and so spotlighting in this presentation. Remember, this is a type 2 diabetic. This is a diabetic that is producing insulin, taking pills, maybe, started on the Jardians, but it's definitely a problem and they bring a case here of a 23-year-old, but it was during COVID, and I think my case is much better. So I'm not really going to go into it. In conclusion, you need to ask the patient, what meds do they take? Okay, this is critical for every EMT. If you see the Jardians or the empagliflozin, right, which looks like the generic name, we need to worry. And maybe they're on other SGLT2 inhibitors, okay? And if they're not getting any carbohydrates, and they're probably not, because most good diabetics are off of carbohydrates. It seems like this particular drug, without the carbohydrates, puts patients into what we call EDKA. And it's being seen. Like I say, since I had my patient, I've met numerous other patients. They could be type 1, type 2 diabetics, and this malaise, this general sickness and the lethargy and the fatigue seems to be what is the telltale sign. Now, this patient, I got to a physician's office, his PMD, and the PMD did a urine stick and found ketones. And so I got a call from the physician from his office that I need to take this patient immediately to the ER. He cannot go home, he cannot pass go, and cannot collect $200 on the way. Immediately from his office. He felt fine. Like I say, the fatigue was the big thing. There was some acetone odor, but the ketones in the urine, which is not a test that we typically do in the back of an ambulance, were there. When I got to NYU, you present the patient. So I said, I'm ruling out DKA. And they're like, okay, what's his sugar? And I'm 140. And then they didn't take me seriously. So I said, no, he was on the Jardians, and we did a test for the ketones at his doctor's office, and it showed. They drew blood, and they found the ketones, and he was rushed by hospital by hospital standards. He was rushed to the ICU, spent a week there, got fixed, and that's really the end of that story. So I wanted to share that. Let's